Director, which stands for Advocacy Group for Elders, of the Senior Source, where she keeps up with issues that affect older adults, educates older adults on these issues, educates elected officials on the issues, and networks with groups on common issues. She is the League of Women Voters, Texas issue chair for health care for those of lesser means and health care for older adults. Is that with the League of Women Voters? Is that what you do with them?
Yeah, that's what Texas. It's the Texas,
Texas issue chair.
not the local.
For health care for those of lesser means and health care for older adults. Serves on the Dallas Area Agency on Aging Advisory Council. Councilwoman Eddie Booth Johnson, Senior Advisory Committee, and was a past chair of the Texas Senior Advocacy Coalition. She was presented with the Distinguished Human Service Professional Award by the Community Council of Greater Dallas, the Distinguished Public Servant Award by the Women's Council of Dallas County, and the Champion for Seniors Award of the Dallas County Adult Protective Services Community Board for her innovative and effective efforts with regard to the prevention of financial exploitation of elder and disabled citizens of Dallas County. Previously, Linda worked for 8 years as the regional coordinator for a state senatorial office. She has taught in the public schools, and she's going to have to explain this, and is twice a graduate of North Texas State University. She is married to Walter Ender, and Linda enjoys bird watching and traveling. And so may I present Miss Linda Ender.
They didn't say she enjoys walking.
No kidding. Well, you know, I thought it might be interesting, since I'm, you know, speaking on a topic that is not pond related, and you know me in one, you know me casually, you know, and you don't know me professionally, and so I thought it might be good to know a little bit about me. So when we were discussing at the last meeting having me do a presentation, there was a lot of discussion about what. And so there were some that wanted or saying, I'm approaching 65. I'm interested in, I'm going to be signing up for Medicare. I'm interested in information in that regard. There were others that were interested in the Affordable Care Act, healthcare reform. For those that don't know those titles, Obamacare, they all mean the same thing, okay? I hope you know that. This man on the street stuff has been amazing to me. Are you in favor of Obamacare? No. Are you in favor of the Affordable Care Act? Yes. Well, they're the same thing. They're the same thing. That's kind of funny to me. Okay, so this presentation that we hit upon we'll have a little bit of that, a little bit of the Affordable Care Act, a little bit that will be helpful to people that are just turning 65, but mainly it is, as titled here, Texas Healthcare 2014, Why Changes Are Needed. So, which is a little bit broader, and my thinking there was that not everybody is an older adult that comes to the meetings, and so even though we have a great many, not everyone is, and so therefore I'd make it just a little bit broader, okay? So
I'm not an older adult.
One thing that has happened with this is I oftentimes invite Mr. Ender to come to one of my presentations because I feel like it might be something he could get something out of, and he always turns me down. So one thing that has happened today is Mr. Ender is going to get some education, so that's a good thing.
And you know why, honey?
And Mr. Ender is also going
for
to...
the lunch.
Yeah, and he's going to listen too, okay? So I'm going to follow this handout pretty much, and if any of you need to get a pen because you think you might want to add notes on it, then go ahead and do that.
I didn't get one, Linda, because I was up there.
Oh, yeah. Sorry.
Here's one.
Well, before I do that, I've given you an agency card from the Senior Source, and file this card away at home. You may not have a need today, but you may in the future have a need. And our agency is a nonprofit agency that serves the greater Dallas area, so that's Dallas County, but surrounding counties. We are a good source for information of all things senior. Could be an acronym, something as simple as an acronym, you don't know what it means, okay? Could be a question about a certain, the phone number's on the card, honey.
Yeah, but you gotta say it for this camera.
Oh. Pretty good. Pretty.
Give him a lapel mic.
Pretty.
So he can
Scroll at the bottom of the
Pretty
screen.
good. And so the number is 214-823-5700, right? And but we're about all things having to do with seniors. So it could be just a simple question. You know, it could be that there's a real need. Someone has a real need. They have a Medicare D prescription drug plan. They don't like it. They want to shop for a new one. How do they do that? Could be that they are really needing assistance. Okay, they can't pay their utility bill, and it is 14 degrees outside, and so that would be something to call on. You're shopping for an assisted living facility or a nursing home facility. We have the Nursing Home Ombudsman Program. And so they take all the complaints of these facilities and can let you know who has the most complaints. What are those complaints? Are they significant ones or just minor things like we don't like the food? And so that's good information for you when you're making that sort of decision. Half of our programs are volunteer opportunities because older adults age healthier if they are engaged in their community. Physically and emotionally, they age better. All the stats show this. We've always had a history with volunteer programs, and we always will because it's so important. Then half of our programs assist in some way. But you have the card, and this isn't an agency presentation. Just tuck it away and remember that we're really a good source for information. I really wish I had known about the Senior Source when Walt and I were doing caregiving for his parents and my father, because it would have saved me, gosh, y'all, hundreds of hours, because I had to seek out all information on my own, educate myself. I was just coming from ground zero. And so if I had only known about this agency, it would have just saved me so much time, effort, stress. I cannot tell you. So, yeah.
Are there any fees associated with it?
There are no fees except 2 years ago we embarked upon a profit-making arm because we had so many people wanting more from our elder support program. Our elder support program assists people and their caregivers in what services are available. And so because people were trusting us and wanting more from us, we started a Elder Care Partners program, which is a geriatric care management program. So where if you need care or you have a relative that needs care, this geriatric care manager could come out, evaluate the situation, come up with a care plan, and then help you. You could execute the care plan, or they could help you do it, or they could totally do it. It would all be depending, and there is an hourly charge for that of $75 an hour. I'll give you an example of how it could be helpful. Like recently, we had a family. There were 5 children in that family, and all of them loved mom dearly, wanted to care for her, but disagreed on how to care for mom. So they called the geriatric care manager, hired them to come up with a care plan. The geriatric care manager made a presentation to the siblings, and they all signed off on the care plan. and that helped with that issue. So also a time where it would be really helpful is you've got, where the children are all working. A lot of women traditionally used to be the caregivers, and now a lot of them are working. They're professionals, and they don't have as much time to dedicate to that. So they could still be a part of the caregiving, but or give part of it, but they've got someone that they can lean on and can do a lot of this the informational stuff. Like they might have them go to, their schedule might not allow them to have the flexibility to go to doctor's appointments. Maybe the geriatric care manager goes to the doctor's appointments with the loved one and reports back to them. That sort of thing can happen. Or you live out of state. The kids are out of state. The loved one is here. The geriatric care manager could be their person on the ground. You know what I mean? So there's a lot of times where a geriatric care manager could be very helpful.
And is all of that out of pocket, or is there anything that's covered by insurance like that?
It would depend on the situation, the person's situation. I think you can tell already that there's a lot of help there with our agency if you need
What
it.
about paying of the bills?
And
I thought that would be interesting. Where they come in,
Oh yeah, well we have a money management program that can help people. A lot of times people can stay in their homes independent longer if they have some assistance with their business matters. They may be able to cook their meals, keep themselves clean, keep house, but when it comes to their business matters, they need a little help. Sometimes it's something as simple as arthritis in your hand and you can't write the checks. And the person is just coming in. You're making all the decisions, but the person is writing the checks for you. It's things like that. We have the guardianship program, so we have an employment program for those that want to get back in the workforce. A lot of people are finding that their retirement is not going stretching as far as they thought it would. So it's a myriad of programs. So.
How big an area do you cover around Dallas?
Dallas and the counties around us. Not so much Tarrant County, though, because they have, substantial programs there themselves.
So like Frisco, Collin County, Denton, all that.
We have our major emphasis is on Dallas and Collin County, but we do service Denton, Rockwall, Kaufman, Ellis.
Well, I know in Carrollton they have senior adult services.
Right.
So is that a similar organization, or maybe kind of like a support organization to Dallas?
Similar in some ways. I would say our
Maybe not
scope.
as comprehensive.
Our scope is more comprehensive. Yeah. Okay. So let's get to the topic. So I think it's good to, because this is going to be kind of the state of healthcare in Texas, all right? So a part of that, of course, would be what's happening at the federal level. And so I think it's good to look at page 2 and remind ourselves why healthcare reform. And the main reason is because there are 50.7 million people in the country who are not insured. In the state of Texas, we have 6.3 million of those people. That's a big hunk, isn't it? Mm-hmm. We have the most uninsured of any state, and it's 1/4 of our population. Okay, so that's one reason for reform. The next is that we have a very wasteful system. Okay, we spend a lot of money, but our results are not as good as a lot of other countries. Okay, and there are a lot of reasons for that. It's unneeded tests, it's a real emphasis on emergency care, and that is related, emergency room care, and that is related to the number of uninsured people. Because if you don't have insurance, what do?
Go to the emergency room.
Before you do that, you try to care for yourself. You try to medicate and care for yourself. And then it doesn't work maybe, and you get worse, and finally you're going to the emergency room for your care, and that's very expensive health care, you guys. And if you can't afford that bill, they'll put you on a payment plan, but if you can't afford it, who is going to pay for that?
We do.
Okay? It will be paid for. It will be paid for by those that do have insurance because the cost will go up in the facility, and then everyone that can pay, or the insurance that pays, will have to pay more. So then your premiums go up, and then if you own a home, if you're you pay into your local hospital tax, and your hospital tax will go up, and there are lots of other ways that that will get paid for, okay? And it gets paid for by other people. And so I think it's good to say that and for people to realize that. There's a lack of emphasis on prevention in our country. I think that's changing, don't you? Because you can't watch a television program anymore that there's not some program about diet, exercise, and prevention of in different ways. And of course, the Affordable Care Act has a real emphasis on prevention. Again and again and again in that act, the word prevention is used, okay? So that's part of it too, because realize this has been law since 2010. Some people don't realize it's been that long. A lot has rolled out and has happened and is affecting the reason why we're hearing so much about prevention. So let's look at some stats on page 3 about Texas. I've already said that we are the #1 state in the union as far as those that are uninsured. But also, we, even though we're a very wealthy state, we have a great deal of poverty too. So the percent that are living below the federal poverty level, we're number 8, okay? And that's usually surprising to people. The percent of low-income population that are covered by Medicaid, we're tied at 48. So we don't have that many people on Medicaid, even though we have great poverty, okay? And that's interesting. Medicaid, a state program for people of lesser means, a safety net, not Medicare, the federal program, okay? Percent of population with employer-based health insurance, we're low there, 43rd. Healthcare expenditures per capita, 46. We spend a lot in our state. We do in Florida in healthcare. It's interesting. Medicaid payments per enrollee, we're 41st. So we don't spend a lot on our Medicaid patients. The percent of
Tied to the fact that we don't have that many people on Medicaid?
No, that's of those that are on Medicaid. Mm-hmm. The percent of non-elderly women with health insurance were 51st.
Wait.
I know.
Where does that number come
Well, and that becomes because either they're putting in the District of Columbia or Guam.
Or Virgin
Probably
Islands?
Guam. So then, let's see. The percent of women who have had a dental visit in the past year, 47th. The rate of women aged 40 plus who received mammograms were 42nd. We're not doing very well with women's health, are we? Part of this could be that, before the Affordable Care Act, before the year 2014 really, where this takes effect, women were paying more for their health insurance than men, okay? So because of the Affordable Care Act, some of these stats may change now because now women won't have to pay more for their health care than men. That was one of the changes in the Affordable Care Act. The rate of women aged 18 plus who received pap smears were 41st. Just not doing very well with women. Also, we're low in the number of physicians that we have. Remember, we have a lot of population in our state, but we're 41st in the number of physicians. We're 44th in the number of dentists, 46th in the number of registered nurses. That's why a lot of you will find when you go to the doctor that you have a lot of foreign-born healthcare folks. My primary care doctor is from Egypt. I've gone to an orthopedic doctor recently. His family is from Iraq originally. Iran. I have a urologist. He's French. Okay? So, it's like a United Nations of doctors, and some of you may have been experiencing the same thing. We're heavily dependent on the Philippines for nurses, heavily dependent on them in our state.
Linda, we have a lot of nursing programs in these universities, in Baylor. has
Sure.
Nursing school, all these nursing schools.
But they cannot train them fast enough. And realize that it takes 10 years to produce a doctor. So this is not something that can turn on a dime. There are some things in the Affordable Care Act to deal with this issue, but again, it doesn't turn on a dime. So it will hopefully get better in the future, but and there are a lot of reasons. That's a whole different presentation about the shortage of healthcare workers. Okay. So let's go to page 6, and let's see who these uninsured people are. Notice that 65 years of age and older that's a very small sliver. Why? Medicare. Wonderful, wonderful Medicare. So thank goodness we have that there for our older adults. And then the children would be, that part of the pie would be larger, except for what? Medicaid and CHIP. Children's Health Insurance Program. Medicaid started out a children's program. It's grown from that, but it still is predominantly a children's program. And so that leaves the main people that are uninsured in our state, but this pie would look similar in any state, are those that are too old for Medicaid and CHIP and too young for Medicare. So that's what's driving a lot of this the healthcare issue. The most insured, let's see, I threw this in because during the debate on the Affordable Care Act, there was a particular time, and you may or may not remember, but immigration came up and the fact that there were those in our country that are undocumented, and you would have thought that they were the ones driving the cost. And so I just saw this, I found this chart and I thought, that's interesting. So you'll note in the state of Texas, 4.1 million, or the great majority, are U.S.-born citizens. Naturalized citizens are 6%. Those are the folks that were born in another country, came here and became citizens. And then those that are not citizens are 26%. But of those, 40% of them are here with visas or green cards. We maybe have even solicited for them to come here for the particular jobs that they do. So by my math, it's 15 point something that are actually here illegally in our state. That's still a significant percentage, but it's not near what you would have thought when you were listening to that debate. And then the pie on page 8, you can study in more depth later, but this is the income of those uninsured, and it's fascinating because it's the gamut, isn't it? And then page 9, just a few basics of the Affordable Care Act. We're hoping, of course, they're hoping to expand coverage to those 50.7 million nationally, the 6.3 million in our state. And it would require anybody, and this is the more controversial part of the issue, it would require anybody who is a U.S. citizen or a legal resident to have health insurance, and if they do not, they will be penalized with a fee. It will begin on their 2014 income tax return. They will be filing that in 2015, so that's next year. So everybody has an opportunity up until March 31st of this year to sign up for their health care if they don't have it already, okay? And that would be on the marketplace. Now, I need to say right here and now, because we have people that are 65 years of age and older in this room, if you are on Medicare, you have no place in the marketplace, okay? It does not apply to you. You have insurance, don't you? You have your Medicare. You have your Medicare, and a lot of people have their supplemental policy that pays the 20% that Medicare doesn't pay, and they have their Medicare D prescription drug plan that pays for their prescriptions, and those people have no place in the marketplace. There are a few people, there are some that are not on Medicare and are 65 and older, and then they could shop in the marketplace. It is actually against the law for anyone to try and sell a policy to somebody that's on Medicare. Okay? Now, I've had people say to me, but can't I go to the marketplace and shop for my supplemental policy? No. There are no supplemental policies in the marketplace. So therefore, if you are on Medicare, you have no place in the marketplace. I want to emphasize that because I'm just scared to death that the older adults will jeopardize their Medicare, and find themselves in a situation they shouldn't be in. Because there's a lot of confusion. For those of you that are not 65 yet, the rollout of the marketplace was in October, and that was the beginning date for the annual enrollment period in Medicare. And so here are all of these companies sending out, wanting people to sign up for Medicare HMOs, Medicare Advantage plans, and they're getting flooded with this mail. And at the same time, you've got all the advertising for the marketplace. And I just couldn't talk to enough groups,
That's exactly my position. I
Yeah.
can stack this tall
You
of
just
stuff.
stand at the recycle bin and you go, nope, yeah.
Yeah. I mean, very confusing for people, very confusing. And so, anyway. Now this fee, the reporting on this fee is not very good because most of the reporting just kind of skims over the fee and says this little fee, or they'll even mention the $95 figure. But it's $95 or 1% of the household income. Now, when you get to 1% of the household income, that could be a lot more than $95, couldn't it, y'all? So I get really upset about the inadequate reporting on that particular issue because people need to know it could be a significant amount of money, this fee.
What about people who don't turn in a tax return? I mean, there's some people who...
There are some exceptions. If your income is so low that you do not do an income tax return, then you are exempted from the Affordable Care Act. There is a long list of exemptions. If you are a Native American, you are exempted because they have money through the reservation or other governmental programs. So there's a list of exemptions, and that's one of them.
So if the fee is 1% of the household income, is it 1% of the gross, 1% of the
gross
net adjustable?
Gross.
Gross.
Mm-hmm. So employers.
Oh, never mind.
Also, employers who have 50 employees or more are required in the Affordable Care Act to provide health insurance for their employees. That has been delayed, but that is a part of it. I think some employers that have 50 or less will want to provide, let's face it, a lot of employers want to. It's been the expense. But what is being created with the Affordable Care Act are big groups. So the costs can get down and decrease from what it has been. So a lot of employers that have 50 or less employees, I think they will take advantage of the SHOP. They have their own marketplace called the SHOP. I think they will take advantage and go there because there are some tax credits available for them to do that. And so I think we'll see some of that happening. Yes.
You are aware now that people hire maybe two different groups of employees so they would work under 40 hours a week and they wouldn't be covered by required health insurance.
They're not in that head count.
They won't be in the head count.
Right.
No,
And can something be done about that? I mean,
Well, no,
I never
because,
understood why employers don't offer that benefit anyway, because you attract better talent when you have better benefits and your company bills. I mean, it's just, to me, it's just not even good business sense.
it's so important. A lot of people wouldn't take a job in a company that didn't offer.
Right.
And, yeah. And it makes for a healthier workforce, too, so.
Well,
So-
also the IRS is coming out with rules, and they're saying, like, if a company has, let's say, 75 people, but they want to be under the 50 full-time, they'll put 26, 28 people on part-time.
That's what he was just saying.
Yeah.
But what the IRS says, we're going to take those part-time people, if they're working 30 hours a week, we're going to add those people up and divide it by 40, and that'll give us the number of employees that are working full-time, and they'll use that number in addition to the regular full-time.
Yeah, there are some new rules now that makes it much more difficult for those companies who have traditionally hired contract people or people who work less than 30 hours a week to avoid, retirement contributions and healthcare benefits and things like that, that are requiring them to do that
So
now.
20 part-time people would not equal 10 full-time people anyway?
Well, if they're like 20 part-time people doing 30 hours a week each,
They're adding the hours and saying
add the hours up,
40
20
hours.
times 30 divided by 40,
Yeah.
that's going to give you the number of workers that would be doing the job full-time at 40 hours. And then that's what's going to be added to it.
That sounds fair.
Now, some states, also, a part of the Affordable Care Act was to expand Medicaid to 133% of the federal poverty level. It was 100%, and now expanding it to 133. Well, this went to court. The two things went through the court system all the way to the Supreme Court. One was, could they have the Affordable Care Act? Could the federal government say that people have to have insurance? And the Supreme Court said, yes, the federal government can do that. Governmental entities can make these type of requirements, like we have driver's licenses, Okay, but the second one was, can you tell the states that they have to expand their state Medicaid program, even though there are federal matching dollars that come to the states? Can the federal government tell the states that they, have to expand Medicaid? And the Supreme Court said no, that you cannot do that.
And Texas
So.
didn't they?
And so what has happened is some states have opted to expand Medicaid and some have opted not to. In our state, our governor came out immediately and said, we will not, in the state of Texas, expand Medicaid. So during the last state legislative session, there were a number of bills filed to expand Medicaid, okay? And the more significant one was filed by Dr. Zerwas, a state representative from Katy, Texas, near Houston. And Dr. Zerwas, knowing how the governor felt, and the governor's stated reason for this was that Medicaid was a failed program, and that we should not put more money into a failed program. That was his logic. So, Dr. Zerwas came up with a bill that had a Texas solution. It was actually stated that way in the bill. A Texas solution for Medicaid, and so there was some reform in that bill, and then it expanded Medicaid to 133% of the federal poverty level. Well, he met with the governor 4 times on this, and the interesting thing is Dr. Zerwas is a Republican, okay? He met with the governor 4 times, and 4 times the governor turned him down. If you were down in Austin, the whole world was for Medicaid expansion. All the medical community, all the doctors, the hospitals, the nursing homes, assisted living, nursing, all the business community, the chambers of commerces, their umbrella group, the business organizations, their umbrella groups. I mean, it was all these nonprofits, it was just swarming with people advocating for the Affordable Care Act, and many of them had audience with the governor. But a lot of the elected officials were not willing to use their political capital knowing that the governor was going to veto. And so therefore, we do not have Medicaid expansion. Now, our governor is not going to run again. We'll have a new governor. Who knows if we'll have Medicaid expansion. You can buy in at any point if you want to, or you can also opt out. Any state that has done Medicaid expansion can at any point opt out. It is, and why was there this groundswell of support for expansion of Medicaid? Well, because it was going to bring $9.7 billion, that's with a B, billion dollars to the state, okay? That was
Through the
one thing.
federal government, right?
Yes.
Yeah.
It would have been, it would have been, well, and for me, it would have insured a lot of people. I mean, you know, a lot of people that weren't insured and didn't have health care would get health care. That, you know, that would happen. But then all this money would be coming into the state too, and we turned it down. And so that's why there was such an incredible groundswell, you know, understanding the high cost that health care is, that it also helped with the high cost. It helped with the high cost of health care, but also this influx of money and turning it down was an issue.
Did the state have to up their part too?
No, this was 100% cost of expansion. Now, after 5 years, it would be 95. It would go to 95%. Okay. And it could, through the years, be more of a match for the state, to be fair. However, the state still can opt out at any point, okay?
Well,
So you could have stayed in for, let's say, 10 years before it starts hurting your budget or affecting it in some way negatively, and you decide to opt out. I mean, you know, and there wouldn't be any penalty
And
or
with
anything.
so many uninsured in our state, it didn't seem logical to me that we wouldn't want to do that.
Yeah.
So,
Well,
Without getting political about it, I can see some correlation to the failed Medicare because of the numbers, you know.
no, it wasn't Medicare, it's Medicaid.
I'm sorry, I mean Medicaid.
Yeah.
So because of the numbers that are represented, you know, by the utilization of the program.
Well, no, we're very low in
I
the
know.
utilization.
That's
Yeah.
what I'm
Yeah.
saying. So, I mean, I can see some indicator for why that program isn't working.
Oh, that more people might be attracted to it. And-
yeah,
Okay, so,
Dick,
I don't want to get off on
Dick and I
Medicaid.
had lunch, and we were discussing several years ago, remember, Dick? And about health care being universal, or everybody trying to get health care. And I said, you know, the guy that just served you the salad, he is a low-income guy, and he doesn't have health insurance, and he has the flu. And he comes in and fixes your salad, and he coughs while he's fixing your salad. And Dick gets the flu, and because he's older, he kicks the bucket.
It's
Poor Dick.
well, the point is, it's a public health issue.
Is it right?
Yeah. Okay, so,
Ask a quick question.
yeah,
Only because I've always been insured. Medicare didn't hit me until I turned 65 and I'm going, okay, so this is my next step, but I'm still working. So I signed up, so I'm not worried about it. I have no clue what it's about. The Medicaid, I really haven't been exposed to Medicaid, so I'm assuming through this discussion is for people that can't afford insurance but are working and don't have insurance?
It's-
I'm not sure what that is.
right. It's
the property
no,
line.
it's a safety net, and it's for children mainly. And then they added long-term care for older adults. So there are some older adults that are getting care
Nursing
that they wouldn't have gotten. It's nursing home or assistance in their home, okay?
Okay.
And severely disabled people. Those are the populations that are under
And
Medicaid.
And
that's
it's
paid
growing.
for by somebody else, or you have to pay
It's
for
a
this?
state program with a federal match.
Okay, all right, okay.
That, I think for
Okay.
a lot of people, and even a lot of people that are under SSI and Medicaid and everything like that, they think that SSI is Social Security.
Well, it is. And that's federal.
Supplemental
That's
security
federal.
income?
Yes, that's federal.
Yeah.
Federal,
But Medicaid is state.
right.
And federal.
Yeah, it's man.
Well, it's considered a state program because the feds have some guidelines and the state has flexibility to pick from their smorgasbord of services and create their own state program.
But
So
it's
it's mainly,
supported.
so it's mainly a state program,
I
but
think
there's some
you
federal
probably
dollars.
said this a while ago.
Okay, now, but we're not gonna get off. Y'all are so interested in this. Yeah, that's good, that's good, that's good. Okay, so,
Keeping it non-political, I do.
Huh?
I appreciate that.
well, that's my job. I mean, I have to just deal in facts. I cannot do any partisan stuff. So, another thing that's happening with the Affordable Care Act is there were people, we had a state high-risk pool, and then when the Affordable Care Act came out, there was a federal high-risk pool that was set up in our state because our governor, again, didn't want to run the federal high-risk pool, so, or that was funded by them. So, but those high-risk pools cost a lot. If people that got their insurance from a high-risk pool paid a lot of money for it. Why?
That's what I'm in.
Okay?
Yeah, it's all sick people who can't get insurance or
Right,
unemployed.
because they have what? Pre-existing conditions.
Uninsured.
Okay.
Right.
And if they didn't pay out the kazoo for this insurance, it would ruin them because their medical costs are so high, or there's the possibility of having medical costs that are so high. So with the Affordable Care Act, as of 2014, nobody no insurance company can turn an individual down for pre-existing conditions. This is whether they have a policy in the marketplace or not. And I hope you all realize that you can buy your insurance from an insurance broker. You know, you don't have to go to the marketplace. But I always recommend everyone go to the marketplace first because they're forming a big group and your costs could be a lot less than going out there solo and buying. So there are a lot of people that are in these risk pools that were just chomping at the bit for, for the marketplace to open because they have been paying such exorbitant price for their insurance. And so they have just couldn't wait, and those policies went away as of December 31st.
They extended it to the end of March now.
Oh, to the end of March? Oh, I guess because of,
Well,
That's the individual.
President Obama allowed, that he gave them the states the option. Because of the trouble with being able to get into the system and
oh, yeah.
getting,
Okay, that makes
a little
sense.
bit of a grace period because of the trouble that they had with
Yeah.
signing up.
Okay, and then this is a fun thing. Part of the Affordable Care Act was, some of you, if you go to a fast food place, you may have noticed that now they have the caloric count for things. And so the idea being, you go into Burger King and you look up there and you see this triple-decker something and you go, oh my gosh, 5,600 calories. Well, I could be satisfied with this at, 590 something calories. You can still buy that triple decker, quadruple decker, whatever, if you want to.
Not in New York.
But
You can't even get an extra large there.
but maybe if you knew the caloric count, you might make a healthier choice. The idea being, so all fast food places have to have caloric count now.
The restaurant.
Quinoa and Greek yogurt now.
And that's another thing, that's another example of prevention, see? That preventative stuff,
Result
I'm
is,
providing affordable care for you, Greg.
And then another thing, and so I just threw this in because they do expect that there will be some savings from the Affordable Care Act, and I'll talk a little bit more about that later. But part of it is the preventative stuff. That won't happen overnight, but in time, if there's enough preventative care, it could affect the cost. And so turn to page 10. And this is a good pie that shows how Medicaid expansion would change the Texas Medicaid budget. If we had expansion, of course, we're not going to have expansion, but look how dramatic that could have been. Okay, this is taking $2008, but okay, now Page 11. This is who Medicaid helps. I told you it was predominantly a children's program, and you can see that from this pie chart. There are a few other programs. These are lesser programs that are not dealing with elderly, disabled, or children. It's assistance for needy families. So there has to be children involved.
Needy, like financial needy, or like just handicap needy? Both, everything?
No, needy, meaning financially.
Okay.
Very small pie, part of the pie though. Okay, so page 12. So some of the reforms, I've already talked about pre-existing conditions. Another change, I told you about women, but now they cannot charge more if you're a woman, or the number of people in the group, occupation, all of that sort of stuff could be done before. However, they still can take age into account, tobacco, geographic area, family composition, and so they're, it would be interesting. It would be.
So when you go in to sign on to that, do they not ask any of those questions before they give you a price?
What questions are you?
Are you female?
No.
None of that stuff is asked.
Not anymore. However, they can ask about your age, your tobacco use. They know where you live,
But they can't
your
say,
family
"Are you a woman?
composition.
Have you ever had diabetes? They can't
No,
ask you any of that.
no.
Now, you do have to tell them if you're female when you get ready to sign up and set up your account and everything,
Yeah,
but it's not
after-
taken into account to the price.
Okay.
Yeah. Okay, so then the coverage for individuals and small businesses must include essential benefits. Now, this is where some of that in the news, where there are some stories about people who they say, these plans have coverage that I don't need, and it's costing more than what I paid. Some of these people had what I call the McDonald's policies, okay? Do you remember that, the news stories? There was a flurry of stories about McDonald's and their insurance coverage that came out quite some time ago. This was like a couple of years ago. And because they offered a health insurance for their employees, but realized most of their employees are very, very young, right? And so the coverage was like minuscule. Like maybe you get, don't hold me to this, y'all, but like maybe you get a one physical a year,
And one doctor visit.
and one physical a year, and after you spent $10,000, it'll pay 20% of your cost or something. I mean, these policies just were not much coverage, okay? And so with the Affordable Care Act, there's a certain level of care. There's a list of benefits. It's about 10. It's just about 10 things. But there's a list of about 10 things that are considered essential benefits, and all the policies in the marketplace have to have these essential benefits, okay? So that's where some of this pushback is coming from, because there are these policies out there that are not much coverage, okay? And they don't have those essential things. And you're hearing about that in the
If
news.
you don't read the fine print, you don't realize you don't have that when you buy it, and then you get caught.
Yeah, well, this is moving over into the insurance for automobile and homes. They say, boy, we can meet your budget and so forth, and you come back and lowly, they halved your coverage, but it met your budget. I ran into that with several of our longtime friends.
It's not fun to read these things, and to compare and all. It is just certainly not fun to do it, but it is really important. And there are no annual limits anymore. There used to be the annual limits to policies. And this is a good thing because, $1 million isn't what it used to be. And a lot of times these plans had like $1 million cap or a $2 million cap. Well, now there are no caps. So, and then page 13, this is a real interesting part of of the Affordable Care Act. Right now, we have a fee-for-service setup, right? So a bill is submitted and Medicare pays, right? Submit, pay, submit, ka-ching, ka-ching, ka-ching. Okay, that's in Medicare. It's in our other insurance policies, isn't it? Unless they have restrictions within that policy. But especially Medicare, it's a real issue of a bill is submitted and it is just paid. Okay, there is no oversight, no real scrutiny of that. Okay, and that's why there's so much fraud in Medicare too.
Tremendous fraud.
So,
Well, I got a question when you just said that. Okay, now I've got Blue Cross Blue Shield. They sent, the doctor or the hospital sends a bill for $5,000. But Blue Cross Blue Shield says, no, it's only worth $400.
right.
And that's all we're gonna say, that, and then they're gonna say, okay, and we're only gonna pay 20% or 80% of that $400 and so what you just said on Medicare, do they have the same process like Blue Cross Blue Shield? Do they cut the doctor's bill or the hospital's bill down?
Yeah, there's a whole article on this that was in Time magazine that, and I've got to get that and carry it with me because I keep wanting to, right after it came out, the title, I knew the title of the article. And now I've forgotten the title of the article. But it took up the whole Time magazine. It was like a book practically. It was such a long and in-depth article. And one of the things that it spent a lot of time on was hospitals and their cost, okay? And so a lot of us, I mean, I thought, God, the poor doctor, the poor facility, they're chopping this thing, in half or taking 2/3 off. After you read this article, you have a whole different understanding. This is totally inflated. They expect the insurance company, Medicare, and you as an individual to negotiate with them. I didn't know that. Did you know that the hospital expects you to negotiate if you have a bill that wasn't paid by your insurance? They expect you to go in and say, this is too high, come down, or this is what I'll pay you? I mean, how many of us know that? This comes out in that article. It's amazing.
So I have to join the insurance company and pay them an exorbitant fee so they can get the rates now.
That's part of it. That's part of it. Okay, so now, to get back to what I was going to say, there's this fee, fee for service setup that is going on right now, okay? So with the Affordable Care Act, one of the changes is moving toward a patient-centered model. What do I mean by that? Okay. What I mean by that is, let's say that you are having a problem with your knee. Okay, Dick? And you go to the doctor and you say, oh, doctor, I am really having problems with my knee. It's gotten worse and worse. I can't step up a curb or down a curb. Can't play with my grandchildren. I've given up my hobby. I can't do the pond anymore, And so it's just really, really bothering me. Can you help me with this knee? And so the doctor says to you, well, let me check your range of motion. Would you walk across the floor here? I'm going to take an x-ray and some blood work. Gets back with you and says, you need a knee specialist, Dick. I'm going to send you over to this knee specialist. So you get over there, and she is going to say, let me check your range of motion, right? Walk across the floor. I'm going to do an x-ray, right? Now, if this person is an expert at, the muscular structure and all of that and decides that, I cannot help you because yours is an issue that can only be corrected by surgery, I'm going to send you over to a knee surgeon. And what is going to happen?
They're going to do the x-rays.
The whole smear again. Now, I will bet you there are some people in this room that have experienced this scenario, or you know someone that has, okay? Now, with a patient-centered, and I actually experienced this this summer, with patient-centered care, and the doctors, by the way, have known that this is coming.
And they hated it.
Even
My
no,
doctor retired because of it.
well, no, I doubt that, because,
No.
but they knew this was coming way before the Affordable Care Act happened, okay? Because something has to be done about the high cost of health care. And everyone agrees on that, it's just how you do it. And so so what you started seeing is groups of doctors pulling together and forming groups. So all the doctors at Baylor are hooked up together in the same computer system. Over at UT Southwestern, even not affiliated with hospitals, there are groups of doctors in different disciplines that are hooked up together on computers and everything. Okay, so they already knew this was coming. So with patient-centered care, Dick goes to his primary care doctor talking about his knee. And all of the observations that doctor makes, and then the test results are put into the computer. When that doctor feels another doctor needs to be brought into the picture, Dick may physically go to another doctor, but that doctor is going to look, they're going to recommend him to a doctor that is plugged into their system, you see. That doctor is going to be looking at all of that data, may ask some questions based upon their expertise, may feel could feel that there is a test that hadn't been run, could, maybe not, but is going to be looking at that existing data and certainly will not be doing the same testing, okay? And I think you can just, it's common sense, you can see how much savings can be done. Also, there's more oversight in this, and hopefully there could be a higher quality of care. Think about it, if there is, more than one set of eyes that are looking at things, okay? So, there is this movement, and both of the items on this page are similar in that they are patient-centered care issues. So, we're moving, and again, this will take a little bit of time. It'll happen faster in some areas than others, but it is a change in the way we're going to do business, and there is opportunity for tremendous savings.
I have one question on that part. If you're, like in my case, being insured, they always give you a listing of all of the doctors that are in your network, so to speak. But how would you know that if this doctor recommends this one, you're hoping it's in the same network and not have to?
In the patient-centered model, you go to your primary care first.
Right.
And that's what everybody wants you to do, okay, is go to your primary care first. The time I broke my ankle and was in New Mexico and broke my ankle, and we came back, I was treated there, but when we came back I needed a cast. The swelling had to go down before I could get a cast. Well, Walt and I had a relationship with Carroll Clinic because, a long relationship with them. So I just went to Carroll Clinic. I didn't go to I bypassed my primary care doctor. Later he finds out, that I had broken my ankle and I went to Carroll Clinic. He's like, not giving me a lecture exactly, but he's letting me know I should have let him know that happened. See, they want that record of everything that's happened to you, in one place, and to use the network of doctors.
I'm just wondering, when you go to your primary care, if they would have a place where you could look at who's in that group, just like we do shared drives.
Most do. If they have a site on the internet, they'll list all the doctors in their group. Mine does.
Okay.
But oftentimes now too, if I need a doctor who's not in my group, they can still talk to each other through some kind of special program, or they can submit X-rays through the internet or something.
You can require it, though.
You can still access your information.
You can require that your doctor send all of your records to your specialist.
Yes, but we're talking about this network.
Yeah.
And the thing is, most of the time, if your doctor refers you to the doctor, they're going to be in your network. I mean, there might be a time where there's a specialty needed that is not in that network, and then, you could say, can you refer me to a doctor that's on my list?
Yeah.
Because
but-
every year we go through the same thing. You have open enrollment and all of a sudden you go, oh, you're not using these people anymore. Now you're using these people. Now I have to go through and look. So I've lost my history, have to start over. So that's why I was just
Yeah.
curious about that.
Okay, so,
I wonder, these companies that want to sell, say, like I have Medicare, and I get letters for people saying, here, you need to get an HMO, you need to get a PPO, you need to expand your Medicare. I don't know what the difference is. I mean, my doctor takes Medicare, and I don't pay. I have a supplemental insurance policy, and I'm not paying anything extra. But what is the advantage of these PPOs and HMOs and everything like that?
Didn't you
They're
just say it
getting
was
your
illegal for them
Medicare
to
money.
solicit those to him anyway?
no, he's talking about Medicare.
I can explain that to you after the meeting if you want.
Well,
I spent 30 years in the insurance business.
That's
so-
an insurance meeting.
It's called sales.
Yeah.
well, not,
I can explain it to
but
you.
no, but it is very confusing to people, and especially for people that are new. Well, no, I won't say even especially. It's confusing for people. And there is a whole, kind of Medicare 101, kind of necessary for that and other similar issues with it. But in essence, if your option is, if you're on Medicare, you can have traditional Medicare, a supplemental policy that pays the 20% that Medicare doesn't pay if you want it, a Medicare D prescription drug policy that pays for your prescription drugs if you want it, and that's one array. Or you could have a Medicare Advantage plan, which is managed care, which puts your traditional Medicare in there, put your supplemental that pays the 20% that Medicare doesn't pay, put your prescription drug coverage in there, and it's all in one policy with paperwork from one company instead of getting from Medicare and from the other two entities. However, it is managed care. Therefore, you can only go to those that insurance policy has an agreement with. The doctors, the facilities that they have an agreement with. If you go out of their network, then you're going to pay more.
Even
if you
doctor
have,
takes Medicare.
yeah, even if your doctor takes Medicare, because but with Medicare, you can go to whatever doctor you want to. That will take Medicare. But so that is the difference. Now I'm glad you brought that up in one regard, because on page 14, these are things that affect older adults, and I'm going to while we're talking about this issue, I won't go in order because we're talking about the Medicare Advantage plans right now, and so you probably have heard some of the news stories where they've said that the Affordable Care Act or Obamacare, notice that I don't use Obamacare, and the reason for that is because the law is called the Affordable Care Act. It was written by Congress. He happened to sign it. I mean, I'm just kind of a stickler for that.
Obama had nothing to do with the Affordable Care Act.
Okay, that's gonna get us into a political discussion, because I totally disagree.
Well, no,
Go back on task.
No, it's not political. It's factual. He had about 10 things he wanted to be included in the Affordable Care Act. The Affordable Care Act was in motion way before he was in office. It was written by Congress. So that is factual. So the Affordable Care, anyway, so let me see, where was I going with that? The Advantage plans. In the news, you hear that the Affordable Care Act is going to take money away from Medicare. You've heard those reports, right? I mean, it's in the news. It's going to take money away from Medicare. Okay, this is what they are talking about. Back a number of years ago, because they've been talking for a lot of years, y'all, about how to get the cost of health care down. And this is not political, but it is factual that they have struggled with this for so many years. And during the Bush administration, one of the suggestions they came up with was that we needed to get Medicare back into managed care. Okay? Now, back in the 90s, Medicare had managed care. Okay? And it got a bad name. People didn't like it. They dropped out of the plans, and the plans went away. So they knew it was going to be hard to get these insurance companies to write policies, Medicare, managed care policies again.
Would it be fair to say that managed care, Medicare is kind of like privatizing Medicare? It's taking it out of the auspices of the federal government, although it's insured by them, but private insurance companies are actually managing your care.
Yes, they are. But that wasn't their think. I mean, their
Right.
thinking was this could be less expensive than traditional Medicare, okay? So, but how are you going to get them to write these policies, you know, when it's, you know, they're going to remember it didn't work before. So, they came up with the idea to incentivize it, okay? So every time a company that has an Advantage plan signs someone up for an Advantage plan, they get a 17% bonus for signing them up. So when the Advantage plans first came out, they were real aggressive in marketing them and selling them, because I mean some of them were like sticking their door. They got in trouble, some of them, because they weren't following the guidelines. They had some restrictions on what they could and couldn't do. They were going door to door. They weren't supposed to. They were phoning people. Yeah, they saw dollar signs, because 17% bonus. You know, that was good. So they were very successful with this. And a lot of people, and so there are now 1 in 4 of everybody on a Medicare is in an Advantage plan because it was so successful. So we've rocked along now for 10 years with these Advantage plans, well, or over 10 years, with these Advantage plans. So now we have a body of data, right? And a lot of statistical data to pull from. And guess what? They've done some evaluation and they found out that it did not save money. It was more expensive. So.
By 17%. That bonus just didn't work.
I don't know if it was by 70% or not. But, so what in the Affordable Care Act, what they're doing is they're getting rid of that bonus. And that's where that money, that's when they say that the Affordable Care Act is taking money from your Medicare. That's what they're talking about. Yeah. So they're taking the bonus away. Now there are some naysayers that are saying, there won't be any more Advantage plans. Well, I don't have a crystal ball, okay, and I'm not going to predict, except that to say, if 1 in 4 of everyone on Medicare is in an Advantage plan, are they going to go away? Maybe some of the policies that don't have as many people enrolled in them will. They're bound to change for sure. They're going to morph them because they're these are insurance policies by insurance companies. So they may get rid of the spa membership that you had for free. They might get rid of any coverage for eyeglasses because traditional Medicare doesn't have that, or dental. There may be changes that happen. Some premiums may go up, or maybe the premium doesn't go up, but the copay goes up. Who knows? That's going to be up to the companies how they morph and change. But if any of you have an Advantage plan, I will say this: watch your mail very closely. This will not happen overnight. It'll happen over a 7-year period, but the 7 years began in 2010. At some point, there will be some changes to these plans, and when that starts happening, then you need to be prepared, intellectually to shop around, shop among Advantage plans, and go back and consider traditional Medicare. Even you're going to need to do that evaluation and to shop around. Also, those of you that have Medicare, you understand the donut hole prescription drug coverage. With the donut hole, you're paying your copay on your meds, you go to the pharmacy, you pay your copay, all of a sudden you get to the donut hole, whoop, you have to pay full price for all your meds, okay? I mean, it's horrible for some people because the medication costs are so high. You know, if you've got chronic illnesses, numerous ones, and you've got new generation drugs and you're spending hundreds of dollars, you know, it's really tough on you when you hit that donut hole. Then after you've spent $4,500 and something of out-of-pocket expense, you come up, woohoo, out of the donut hole. It pays really, really good. The plan will pay 95%, you only pay 5%, but that donut hole is just hellish. And so they're trying to close it up in the Affordable Care Act. They've made some progress. President Obama made a deal with the pharmaceutical companies that in the donut hole, the pharmaceutical companies would pay half the cost of name brand drugs. You'd pay full for your generic, but for name brand half, and that has helped people. But the donut hole will not totally close up until the year 2020. But that happened. They also added new preventative benefits. Anything preventative, there's no copay under Medicare anymore. That's a change.
Can I elaborate on that one just a second? My insurance pays 100% on my well visit or my annual physical. But if they find anything wrong with you, it's no longer a well visit.
Right.
Well, it all depends on what the doctor puts on the bill.
That's what I told him. He said, I can't lie. And I'm like, but that doesn't make sense to me. So I come in for a physical and you say, well, we're going to
the wellness exam
medication.
Yeah, but the wellness exam is not the physical. But this takes a lot of education to the public.
Right.
Why they did this friggin' wellness exam, I don't know. I mean, I understand it, but it's very, very confusing. It's not your physical. It's not your annual exam, really. It's a wellness exam. It's a go in and sit down and talk about the state of your health. And it's basically a kind of a checklist. And it's, you know, is this still and this still, and are you still taking this and this and this? And that's it. If any tests are run, all of a sudden, it is not a wellness exam. It is now a physical, or it's a diagnostic, or it's an office visit. Okay, it's either if you bring up something new, like
my foot hurts.
Yeah,
Boom.
yeah. Now it is not a wellness exam. Okay, so. That's the tough thing about it and educating people on it. When I do just strictly the changes in Medicare, I have supplemental handouts about that and the preventative care, what is covered, that I bring with that. But, that's not what we were doing today.
The thing is they're splitting them up in 2 visits. You come in, they run all the tests, and then you have to come back to get all the results. And I'm like, that's just crazy. Very frustrating.
Email me.
Or why couldn't you just do the wellness exam and now say, okay, wellness exam is over, and now do an office visit or the physical or whatever. Yeah.
I had one other thing I wanted to add before you move on about prescriptions and stuff, just because this was enlightening to me. Maybe everybody knew about it but me. But my son went in to refill a prescription that he has that he actually, when he was first prescribed the medication, he wrote to the pharmaceutical company and they gave him a 1-year benefit so he could fill that prescription all year long for free. And then at the end of that year, it was no longer active, and so he was going to have to start paying for it. And he went to fill the prescription, and the pharmacist, bless his heart, goes, "Wow, it's $157." And my son's like, "Yeah, I know." And he goes, "Don't you have a coupon or something?" And he's like, "No, just pay for it." And he goes, "Let me check." He went online, found a coupon with the pharmaceutical, came back, and he goes, $12. And my son said, "Really? Cool, thank you." He thought he meant it was a $12 discount. It was $12 for the prescription because there was a coupon with the pharmaceutical company that manufactured the drug. So just in case you don't know that, check for those things.
Let me tell you, I've got a friend that never buys anything without going online and looking for a coupon. It's amazing how much she saves. There's a coupon for everything out there. It's amazing.
And you can price your drugs among various pharmacies and the pricing will be different.
Right,
If you're
right.
paying full price or retail,
Right.
because it depends on their volume and what their contract.
That's why when you're signing up for Medicare D, they ask you what your pharmacy, what pharmacy you use. That enters into the cost. The dosage you take of a medication can even enter into the cost. It's fascinating. So, anyway.
And individual pharmacies will have their own discount program too, like Walgreens.
Yeah, they have those
You
$4
pay
things.
$20 a year, okay? My prescription that I take, have to take daily is 40, 50 bucks, okay? I pay the $20 a year, then each time I refill the prescription, which is quarterly, it costs me $2.
And you can ask your
Yeah,
doctor.
but you gotta be careful. Walgreens, if you have a prescription drug plan, they will not give you their discount.
Right, that is correct. That's why I don't have a prescription drug plan.
You can ask your doctor to write you a 1-year prescription and get it by mail for way cheaper. Anything that's more than a 30-day prescription costs you less. There's just so many tricks that you have to know about.
Yeah, and they make a difference.
Filled up in Canada.
So here are some important dates that I've put down for you. Please note, those of you that are on Medicare, note that we are in an enrollment period right now. At the very bottom, the last date, January the 17th to February the 14th. This does not mean that you can roll in things or move. It is a disenrollment. You can, if you don't like your Medicare Advantage plan, you can get out of it and go back to traditional Medicare or to another Advantage plan during this period. Your real open enrollment period or your annual enrollment period is in October 15th to December 7th. So, anyway, after all of this, will everyone in the state of Texas be insured?
No.
No. No. One reason is we don't have Medicaid expansion, and guess what? Those people that could have qualified for Medicaid expansion and now cannot get on Medicaid, they can go to the marketplace if they can afford it. They may not be able to afford it. But if they could afford it, they could go to the marketplace and buy. But guess what? They can't get the tax credits. They can't qualify for it because, see, the way the Affordable Care Act was set up, that if you're 133% of the poverty level, you go to Medicaid. You don't go to the marketplace. See? So they can't do the tax credits. That's what will probably, if the tax credits were available to them, some of those people might have gotten captured by the marketplace. But because they're going to be low income, and they can't get the tax incentive, they may not. So that's one reason. Okay, then the other will be that we do have a number of undocumented people in our state, because being a border state, and so some of them, if their employer is not providing and they cannot afford it, then they would go without insurance. If you're a naturalized citizen, or a permanent resident, you're here legally, you're a permanent resident, you can purchase from the marketplace, but you would not be able to, if you're low income, you would not be able to qualify for Medicaid because you're not a citizen. Only citizens, can qualify for Medicaid. And then there will be those that are, by gosh, the government's not going to tell me what to do. They'll pay their fee or they'll try and get out of it. And then there will be those that will are wealthy enough to self-insure. They'll self-insure. So not everybody in our state will end up being insured, even though we have all of these options now. So I think we've done questions along the way, but if anyone has one, I'll entertain it. Okay?
Okay, thank you.
That was excellent.
Thank you, that was great.
And the more complicated it gets.